I want to tell you about a conversation I have had more times than I can count. A patient sits across from me, usually somewhere between 65 and 75, usually someone who, by every outward measure, appears healthy and engaged and on top of their life. And I show them their ECG. And I point to a specific pattern in the tracing. And I tell them that this pattern is consistent with a myocardial infarction that occurred in the past. Not recently, weeks ago, sometimes months, and they look at me with an expression that I have come to recognize immediately. Not fear, not confusion, something quieter than both of those things, a kind of recalibration. Because they are running back through the last several months, searching for the event, searching for the moment that should have been unmistakable. The crushing chest pain, the dramatic collapse, the obvious emergency that sent them to hospital, and they cannot find it. Because there was no dramatic moment. There was no obvious emergency. There was just a week, perhaps 6 weeks ago, when they felt more tired than usual. When they did not feel quite like themselves. When something was slightly off in a way they could not name precisely enough to act on. That is the conversation. And it happens because there is one symptom, one specific, reproducible, physiologically explicable symptom that is the most common presenting feature of a silent heart attack in adults over 60. And that is simultaneously the most universally dismissed, most consistently attributed to other causes, and most dangerous to ignore. Today, I am going to tell you exactly what that symptom is, why it occurs, at the level of the physiology, not just the surface description, how to distinguish it, specifically and practically, from the ordinary version of the same experience that you have had 100 times without consequence, and what to do when you notice it. This is, in my clinical opinion, the single most important piece of cardiac education I can give to anyone over 60, because the symptom I am going to describe is not exotic or obscure. You have felt it before. Everyone over 60 has felt it, and that familiarity is precisely what makes it so dangerous. Because the brain files familiar things under known, benign categories without examining them carefully. And when this symptom is cardiac in origin, that filing system can be fatal. Before I name it, I need to walk you through the physiology. Because the symptom only makes complete sense, the kind of sense that changes how you respond to it, once you understand what the heart is actually doing when it produces it. The heart is a muscle. And like every other muscle in the body, it requires a continuous, uninterrupted supply of oxygenated blood to function. That supply comes through the coronary arteries, 3 main vessels and their branches that run across the surface of the heart and penetrate into the myocardial tissue, delivering oxygen and nutrients to every layer of cardiac muscle. In a classic acute myocardial infarction, one of these arteries is suddenly and completely blocked, usually by the rupture of an atherosclerotic plaque and the rapid formation of a clot at the rupture site. Blood flow stops. The muscle supplied by that artery begins to die within minutes. The ischemia is severe, immediate, and triggers the intense, dramatic pain response that most people associate with a heart attack. But that is not the only way a heart attack happens. In a significant proportion of cardiac events, particularly in older adults, the process is different. A plaque that has been building in a coronary artery for years begins to narrow the vessel progressively, or a plaque ruptures partially, forming a clot that reduces but does not completely eliminate blood flow. Or the coronary artery goes into spasm, a sustained contraction of the arterial wall that restricts flow significantly without any plaque rupture at all. The result in all of these cases is ischemia, insufficient oxygen delivery to cardiac muscle, but the ischemia is partial rather than complete, gradual rather than sudden, or intermittent rather than continuous. In this scenario, the heart muscle is not dying rapidly. It is struggling. It is receiving enough blood to survive, but not enough to function at its normal efficiency. And the body's response to this situation, the compensatory mechanisms it activates to try to maintain adequate cardiac output despite the compromised supply, produces a specific set of systemic effects. The heart works harder. It increases its contractile effort. It may speed its rate slightly. These compensatory mechanisms are metabolically expensive. They consume more oxygen at precisely the moment when oxygen delivery is already reduced. The body, which monitors cardiac output continuously through a complex system of pressure receptors, chemoreceptors, and hormonal signals, detects the insufficiency. It begins to redirect resources. It diverts blood preferentially to the heart and brain, reducing perfusion to skeletal muscle and peripheral tissues. It activates the sympathetic nervous system at a low level, raising circulating catecholamines. It releases hormones from the ischemic cardiac muscle itself, including BNP, brain natriuretic peptide, that signal physiological stress throughout the body. The systemic result of all of this, the subjective experience that the body produces in response to the heart's struggle, is the symptom I am about to describe. The number one silent heart attack symptom in adults over 60 is fatigue, not tiredness. I want to be precise about that distinction because it matters enormously, and the imprecision is part of why this symptom is so consistently missed. Tiredness is what you feel at the end of a long day. Tiredness is what you feel after poor sleep, after physical exertion, after a week of stress. Tiredness is familiar. Tiredness has an explanation that you can point to, and tiredness resolves, reliably and predictably, with rest, with sleep, with a quiet day. The fatigue I am describing is different in every one of those dimensions, and learning to recognize those differences is the entire practical purpose of this video. This fatigue is disproportionate to your activity level. You have not done anything that should produce this level of exhaustion. You woke up after a reasonable night's sleep, and within 2 or 3 hours felt as though you had already run a marathon, or you are doing something you have done without difficulty 100 times. Making lunch, walking to the car, climbing a single flight of stairs, and the effort required feels suddenly and inexplicably wrong, as though the calibration has shifted, as though the same task that cost you nothing yesterday is costing you significantly more today, and you cannot identify why. This fatigue does not resolve with rest. This is the single most important distinguishing feature. You sit down, you rest for an hour, you sleep, and when you get up, it is still there. Not with the same intensity perhaps, but present in a way that ordinary tiredness is not. Ordinary tiredness has a bottom. You rest enough and it is gone. Cardiac fatigue has no clean bottom. It persists. It colors the day with a heaviness that rest does not lift in the way you expect it to. This fatigue has a quality that patients consistently struggle to describe precisely, and the consistency of their struggle to describe it is itself clinically meaningful. The words I hear most often are heavy, deep, as though something is wrong, as though the body is working on something that you are not consciously aware of. One of my patients, a retired engineer named David, 69 years old, who came to me after his wife insisted he attend because he had been, in her words, not himself for 10 days, described it as feeling like he was running software in the background that was taking up all the processing power. He was functional, he was present, but everything was slower, heavier, required more effort than it should. His ECG showed a lateral wall infarction of indeterminate age, somewhere in the previous 2 to 4 weeks. He could not identify the day it began. Neither could she. This fatigue is often accompanied by a very specific reluctance, an uncharacteristic withdrawal from activity and engagement that is noticed by the people around the person before the person themselves fully recognizes it. Spouses and adult children notice it first, consistently. They describe a person who has become quieter, who is sitting down more, who has declined to do things they would normally have done without hesitation, who seems not dramatically unwell, but somehow diminished, less energetic, less present, less themselves. That observation, from the people who know you, is clinically important. If someone who knows you well has said to you recently that you do not seem yourself, that you seem tired, that you are less engaged than usual, and you have attributed it to age, to the weather, to a mild bug you may be getting, I want that observation to carry more weight for you after today than it did before. Now I want to address the question that I know is forming for many of you watching this, because it is the right question and it deserves a direct answer. How do I know when this fatigue is cardiac and when it is one of the dozens of other things that cause fatigue in adults over 60? It is a legitimate concern. Fatigue is one of the most non-specific symptoms in medicine. It is associated with anemia, with hypothyroidism, with depression, with sleep apnea, with vitamin B12 deficiency, with medication side effects, with deconditioning, with viral illness. I am not suggesting that every episode of unusual fatigue is a cardiac event. That would be both inaccurate and unhelpful. What I am suggesting is that there is a specific combination of features that, when present together, shifts the probability significantly toward a cardiac cause and warrants urgent evaluation rather than watchful waiting. And those features are as follows. The fatigue is new, not a worsening of a chronic baseline tiredness you have had for years, but a change from your recent normal, something that arrived in the last days to weeks and represents a departure from how you have been functioning. The fatigue is accompanied by at least one other symptom from the following list. Mild breathlessness that is new and not explained by a respiratory illness. Any discomfort, however mild, however brief, in the chest, jaw, neck, shoulders, upper back, or upper abdomen. A sense of the heart beating unusually, not necessarily fast, but heavy or slightly irregular, or with an awareness that was not there before. Lightheadedness or dizziness without a clear positional or dietary explanation, or a vague, persistent sense that something is wrong that you cannot specifically identify, but that is real enough to have crossed your mind more than once. The fatigue did not resolve after adequate rest over 48 to 72 hours. You have slept. You have rested. It is still present. If all three of those criteria are met, new fatigue representing a change from your baseline, accompanied by any additional symptom, persisting despite adequate rest, that is the profile that warrants a same-day medical evaluation. An ECG, blood tests including troponin, which is the most sensitive marker of cardiac muscle damage currently available. A clinical assessment, not a scheduled appointment next week, a same-day evaluation. I want to talk specifically about why this symptom is so dramatically more common in adults over 60 than in younger adults. Because the age specificity is not arbitrary, it reflects real physiological changes that make the older heart both more vulnerable to ischemia and more likely to produce atypical symptoms when ischemia occurs. The first factor is autonomic neuropathy. As I described in the context of silent myocardial infarctions more broadly, the autonomic nerve fibers that transmit pain from the heart undergo age-related changes that reduce the intensity and clarity of ischemic pain signals. The heart may be genuinely ischemic, genuinely producing the cellular signals of distress, but those signals are attenuated before they reach conscious awareness. What reaches consciousness is not pain, but the systemic effects of a struggling heart, the fatigue, the breathlessness, the heaviness. The second factor is reduced cardiac reserve. A younger heart has substantial reserve capacity. It can increase its output dramatically in response to demand, compensating for partial ischemia without producing systemic symptoms until the ischemia is severe. The older heart has less reserve. The same degree of arterial narrowing that would produce no symptoms in a 50-year-old may exhaust the compensatory capacity of a 70-year-old heart and produce significant systemic fatigue at relatively low levels of physical demand. The third factor is the higher prevalence of silent ischemic burden, the accumulated effect of years of subclinical coronary artery disease that has never been formally diagnosed. Many adults over 60 are walking around with significant coronary artery disease that has been progressing slowly for decades, producing no dramatic symptoms, occasionally producing episodes of unusual fatigue or mild breathlessness that were attributed to other causes and never evaluated. The event that finally produces a measurable infarction may be a relatively small additional insult on top of a large existing burden. The fourth factor is the gender dimension, which I want to address specifically because it carries life or death implications. In women, the presentation of cardiac ischemia as fatigue rather than chest pain is disproportionately common. This reflects both hormonal influences on cardiac pain pathways and the higher prevalence of microvascular disease in women, which affects the small coronary vessels rather than the large ones, and produces ischemia through a different mechanism that is even more prone to atypical presentation. Research published in Circulation found that women experiencing myocardial infarction reported unusual fatigue as their most prominent symptom in over 70% of cases, and that a substantial proportion of these women reported that their symptoms were initially attributed to anxiety or stress by the first clinician they contacted. I say this not to critique individual clinicians who are working within the constraints of limited consultation time and pattern matching trained on decades of male-predominant cardiac research, but to empower women watching this. If you have presented with unusual fatigue and been told it is likely stress or anxiety, and it has persisted, push. Request an ECG. Request a troponin level. Those two tests take minutes, and they are the difference between finding the answer and not finding it. Let me tell you about Eleanor. Eleanor was 71. She was active, a daily walker, a gardener, someone who by her own account had never given her health much reason for concern beyond the routine management of mild hypertension and slightly elevated cholesterol. She came to me not because she thought anything was seriously wrong, but because her daughter had called me and asked me to see her. The daughter's description was this: "Mom has not been herself for 2 weeks. She is not complaining. She says she is fine, but she is not going on her walks. She is sitting down a lot. She fell asleep in the armchair at 4 o'clock on a Tuesday, which she has never done in my lifetime." Eleanor, when I saw her, agreed that she had felt more tired than usual. She attributed it to the heat. It had been a warm spell. She had also, she mentioned almost in passing as though it were entirely incidental, felt a bit short of breath doing the stairs a few mornings. And once, perhaps 10 days ago, she had felt a strange heaviness across her shoulders that had lasted about an hour and then gone. Her ECG showed an inferior wall myocardial infarction. Her troponin was mildly elevated, not at the dramatic levels of an acute event, but elevated in a way consistent with ongoing low-grade myocardial stress. She was admitted. Her angiogram showed a significant stenosis in the right coronary artery. She had a stent placed that afternoon. She went home 4 days later. Her daughter asked me, when we spoke after Eleanor's discharge, how close it had been. I told her that the honest answer was, closer than Eleanor ever knew. The pattern of symptoms she had been dismissing for 2 weeks, the fatigue, the breathlessness on stairs, the shoulder heaviness, had been a cardiac event in slow motion. The stent was placed before the ischemia produced a large, permanent infarction. She was lucky. She was lucky because her daughter noticed what she would not have noticed herself. She was lucky because that daughter called me. She was lucky because the ECG was done that day rather than scheduled for next week. That luck, I want to be direct with you, is not something you should have to rely on. So here is what I want you to take from today. Practically, specifically, know your baseline. The most important reference point for detecting cardiac fatigue is knowing what your normal energy level feels like, so that when it changes, you notice the change. This sounds obvious. It is less obvious in practice because the changes that precede a silent heart attack are often gradual enough that they do not register as a sharp departure. Pay attention to what your mornings feel like, to what your usual activities cost you, so that when the cost changes, you have a reference point. Take new, unexplained fatigue seriously after 48 hours. 1 day of unusual tiredness. Attribute it to the usual suspects and rest. 2 to 3 days of fatigue that is not resolving, is not explained, and represents a change from your recent baseline. That warrants a phone call to your doctor or an urgent care visit. Not because it is definitely cardiac, but because it needs to be evaluated to determine whether it is. Never let the mildness of a symptom be the reason you do not seek evaluation. The symptoms of a silent cardiac event are, by definition, mild enough that they do not compel action on their own. The danger is not that you cannot feel them. It is that you can feel them. You recognize that they are unusual, and you decide they are not serious enough to act on. That decision, made reasonably and understandably, with incomplete information, is the decision that costs lives. Mild does not mean safe. Atypical does not mean benign. Persistent and unexplained is always sufficient reason to be evaluated. And finally, listen to the people who know you. If someone who knows you well has said recently that you do not seem yourself, take that observation as data. They are seeing something that familiarity with your own body may be obscuring from you. The people who love you are, in this specific context, better positioned than you are to detect the subtle change that cardiac fatigue produces. Their concern is not anxiety, it is information. Act on it. The heart is a 400-gram muscle working continuously, without pause, from the moment before you are born until the moment you die. It does not send dramatic signals when it is struggling. It sends quiet ones, a heaviness, a slowing, a tiredness that does not lift. Learn to hear those signals, because your heart is not dramatic, but it is speaking. If this video gave you something useful, something that clarified a symptom you have been uncertain about, or that prompted a conversation with a family member who needs to hear this, please share it. Leave a comment telling me what you will do differently after watching today. Those comments reach people who need this information, and they shape the clinical topics I cover next. I am Dr. Julian Cross. Take care of your hearts, and I will see you in the next one.